All right, Dr. Bowen.
I'm Jim Bowen. I'm the medical director for the Multiple Sclerosis Center here at Swedish. And it's my pleasure today to introduce our speaker, Enrique Alavarez. He's a colleague I've known for many years, currently at the University of Colorado. He did his medical school and went through the MSTP program, the MD Ph.D. program at University of Colorado. He stayed on for his internship and then did his residency and a fellowship in neuroimmunology at Washington University in St. Louis. While there, he overlapped with our own Dr. Chen, who's at our institution now. Enrique is now an associate professor of neurology at the University of Colorado, where he has concentrated his research in neuroimmunology and also in clinical trials of patients with neuroimmunology diseases, particularly multiple sclerosis. His topic today is going to be B-cell depletion and de-escalation as an MS treatment strategy. So Enrique, thank you for joining us, and I look forward to hearing your talk.
No, that's awesome. Let me go ahead and start sharing my screen. Thank you very much for the invitation. This is a little bit of a hodgepodge presentation, so I apologize for that. But as my wife likes to point out, I like to jump from topic to topic, so it's a little bit of random things kind of put together. But we're a center that takes that uses a lot of B-cell depletion, and we've used them for a long time. And so it's a little bit of tips and tricks that we've kind of learned about using these drugs and kind of what our experience has been and what led us to maybe using kind of higher efficacy therapies early and now kind of what we're doing afterwards with de-escalation. I'm a conflicted individual. Let's see. Oh, it's not sharing the right screen. Hang on, let me try and do this again. Is that sharing the right screen?
We can see it.
Okay.
It's still on your very first slide.
Okay. Let's see. There we go. All right. And so conflicted mostly with a lot of the different drugs that produce a lot of the drugs for MS. We'll talk a little bit about the value of real world data. As I mentioned, some of the practical tips of using B-cell depletion therapies. And then the part I'm most excited about is sort of this understanding how to use drugs and when and how the risk-benefit ratio kind of changes over a lifetime of a patient. So as we understand immunosenescence, how the risks kind of go up over time and the benefits probably go down over time as well. So one of the beautiful things about our field is that we have a lot of drugs that we can use and have at our disposal. There's unfortunately not great data for ibrutinib, so I've kind of started crossing some of these off, and we'll see if the BTK inhibitors might be coming down, but that's the up and coming, and we'll see where we end up at. This looks very different if we look at progressive disease, and I've included rituximab because we do have a fair amount of use of it in the state of Colorado, as we get access to it through Medicaid and Medicare often. But how to decide between these drugs, at least for the relapsing patients, can be tricky with so many options. And I think a lot of us have a diagram similar to this, and this one goes back a while. This is a diagram from a publication by Dr. Hauser that kind of compares safety and efficacy. And I think, all of us have a little bit of a different placement between these drugs, but you tend to kind of see that higher efficacy therapies might have a little bit more risk or less safety, I guess. The other problem that kind of comes into this is a little bit is we're not the only ones that get to pick and choose the drugs. And unfortunately, we still have to kind of consider cost and insurance coverage for these drugs. But again, we kind of place them in these. And you'll see differences between rituximab and Ocrevus on this diagram. This was, really sort of about the time in 2013 before Ocrevus had done their phase 3 trials. And so just as information comes out, again, that we move these around some. One of the things about MS is that as we start to kind of look at the lifetime of a patient and we look at inflammatory disease activity, whether that's relapse or with MRIs, is that there is a decrease of these events over time. So the younger the patients, the more active their immune systems and the more it can kind of attack them. Unfortunately, the disability kind of looks the opposite and it kind of keeps accumulating. And whether we look at that as disability or brain volume loss, it ends up, again, looking the opposite to that. And the trick, I think, for us has been, a little bit to coin the term from stroke, time is brain, is, the earlier you intervene, the better you can do. And so, again, none of this stuff, I think, is that novel or thought-provoking. But just to kind of start saying, we're not going to get clinical trials to separate and identify this data. So we have to turn over to real world data, I think, to kind of get data to support some of these arguments. This was a paper that came in 2020 that looked at 10-year data looking at the disability changes of patients as they started on high efficacy therapy, either as an early treatment option or later on in the disease course of patients. And we can see that patients, once balanced out, that those that started earlier accumulated less disability at 8 years compared to those that started high efficacy therapies, but started them after having started other therapies first and then escalating to those high efficacy therapies. The interesting part is even if we re-baseline and we do this at 5 years, so we're starting here again, and we kind of balance out, is that we see that there's a continued benefit to having done that switch early. And so again, this is, in this case, 6 years. And then we see that, something we did 6 years prior actually still benefited these patients down the line. The EDSS of 6, EDSS is the standard disability scale that we use for a lot of clinical trials, and a 6 basically means using a cane. In the past, prior to therapy availability for MS, we would say that about 50% of patients at 10 years would require a cane. But if we can see here the change of starting a disease, high efficacy therapy later in life, that number is reduced to 11%. And if we do it early, that we can get that number to 3.4%. So again, a big difference with these therapies on disability outcomes in patients. So just to tell you a little bit about our experience and put some numbers and experience within our center. And part of the reason I'll be talking about B-cell depletion is that we follow about 4,000 patients, primarily at the Rocky Mountain MS Center at CU. I see patients at Denver Health, and we follow about 400 patients there. One of my colleagues goes to the VA hospital that's here. And before Ocrevus was around, we used a lot of rituximab, so we had greater than 1,200 patients on rituximab. That number's come down some because ocrelizumab got approved, and then we've probably are over 100 patients now on ofatumumab, and we started to use a little bit of ublituximab, which is the newest kid on the block, but haven't used it a ton quite yet. This is kind of the location of the different hospitals. The VA will eventually get built in this side of the hospital in downtown. The county hospital of Denver Health is down here, and this is kind of where our clinics are at. So one of the things is because we've used these drugs, and the other ones that we used a lot were Tisabri before rituximab was available, fingolimod or Gilenya or dimethyl fumarate or Tecfidera. We were able to use our experience with these drugs to kind of compare them. One of the things that when I was starting off in the field, I'm starting to sound old now, was that these drugs really, there wasn't much difference between them. And we had to really kind of convince people that these drugs actually had some effect. And the nice thing about doing real world studies is that you can easily, from just one center, you can see the number of patients that we were able to include in these trials kind of gradually over time. And we can look at a lot of the clinical outcomes that traditionally you might look at in more controlled studies like phase 3 trials with relapses or MRI enhancing lesions, new T2 lesions, or kind of combine them to kind of come up with a composite effectiveness measure. And we could see that there were differences between these drugs. We started off with gelinium dimethyl fumarate, and we didn't see necessarily a ton of differences between these two drugs. We added natalizumab so that we could see some differences. And then as we gained more experience with rituximab, we were able to start adding in rituximab. And the difference between these two were a little bit more borderline. But, you know, the patients that you would put on these drugs are not the same patients as you might put on the oral therapies. And so we can do some statistical manipulation of these patients and look at these patients using propensity scoring or matching to be able to kind of match up the patients and actually get a better sense as to the differences between these drugs. And so when we looked at rituximab and compared it to natalizumab, for example, we can see that maybe there was a trend to maybe a little bit of a difference, not statistically significant. So not much difference between them, but we could see differences between fingolimod and dimethyl fumarate that were indicating that they were maybe about 3 times better at reducing relapses and MRI measures. To us, then we started to be able to say, hey, there's differences between these drugs. We can see these in our experience. And I think that that's where we started to kind of see much more use of these higher efficacy therapies. This is kind of what it looks like over time, where we can see that rituximab and natalizumab look fairly similar. And then we start to see a little bit of a separation between them, that the orals look very similar between them. And if we readjust between natalizumab and rituximab after 6 months, that we started to kind of actually see some differences, actually suggesting that maybe B-cell depletion was a little bit better than natalizumab. When we look at side effect profiles, we can see a lot of the same things that we would normally pick up on clinical trials. With natalizumab, we can see that there were infusion reactions. So sometimes within, flushing, rashes, hot flashes, this kind of stuff that maybe we associate more with dimethyl fumarate, and those numbers are definitely higher with dimethyl fumarate. But we could see some of that, and we'll get into that a little bit with neutralizing antibodies to natalizumab. Infections, which is the big concern with lowering the immune system. And again, we can see that we can pick up some differences. And if we looked at these drugs, the ones that we would associate more with infections would be rituximab and fingolimod, maybe a little bit less with some of the other drugs. And so we can kind of see those trends and differences using this data. Fingolimod has kind of fallen out of favor because of a lot of other side effects. And we can see that we can pick these up again as well. And then here with flushing on dimethyl fumarate. So when we can look at these a couple different ways. If some of the events happen early, you might not discontinue the patient. You'd say the drug is maybe just taking effect. And so we can look at it as discontinuations. The discontinuations, it's interesting to note how high they are. So this is a 2-year study. And we could see that on some of the better drugs that number might be down, only 25% of patients will drop out, and up to maybe 50% of patients might drop out with dimethyl fumarate with a lot of its GI issues. But as we start to look at sort of the reasons for dropping out, disease activity was a fairly small component of these drugs, suggesting again that they're really pretty effective drugs, and we can look at patients and tell them like, hey, we got this, we can cover things well. We can see, though, that part of the reason for the failure for and some of the differences in trends, maybe for natalizumab over rituximab, is the presence of neutralizing antibodies. So of the 11 patients that discontinued natalizumab, half of them had neutralizing antibodies. Those take time to form, and that's probably part of the reason why the separation in the curves took a while to kind of be able to see. When we look at adverse events, the difference between natalizumab, again, extended here, where we could see that over a third of the patients had those neutralizing antibodies. The reason for dropouts for a lot of the B-cell depletion was insurance, because especially a lot of times with rituximab being off-label, as patients change insurance and things like this, they just got hard to get approved. And so patients would end up having to switch out to other treatments. Most of the failures were really for adverse events. And you can see again with the orals, the higher issues with, especially dimethyl fumarate with GI issues. loss to follow-up and things like this. Again, these are not controlled clinical trials where you have study coordinators that can keep calling patients. So, these are some of the differences that we do see in real-world studies compared to more controlled studies. One of the interesting things when we start to see about efficacy of drugs, if we look at a blood biomarker of nerve damage, neurofilament light, and use that to kind of predict, and we can say, how good are these drugs? When we look at sort of the lower tier drugs, teriflunomide or Abagia in this case, we can see that those patients with lower levels had less MRI activity than those that were having higher levels of neurofilament light. When we put those patients on high efficacy therapy, we don't see those differences. And so one of the concepts here is that it's hard sometimes to predict who's going to go on to have disease activity. If we go back to our slides here, we already looked at patients and pre-selected patients because these are not randomized that might need a higher efficacy therapy versus not, and that's why we had to use that propensity matching. So even with using all the same tools that we normally would in clinic, we were still not predicting and would fail our abilities to predict who was going to do well on an oral, and more of those patients were still failing. We don't have to think about it that much with higher efficacy therapies, and I think that that's part of the reason with this idea of using higher efficacy therapies that really gets pushed up. So we start to look a little bit at also like, could we predict what were the factors that might help us predict who could go on orals versus infusions. And we already kind of showed that age was an important one up front. And so we'll go back and look at age again a lot more detail. So if we split the age into quartiles, and we combined the drugs that were orals and infusibles, because again, the efficacy was fairly similar between those drugs, we can see that the chances of them having disease activity, that the difference between these drugs is much higher when patients are younger. And as they get older, that these differences really kind of start to fall out, that there's not as much difference. If you have less disease activity, you may not need as strong of a medicine to be able to control these patients. So the differences kind of fall off. We can plot this a little bit more linearly, and we can see this decrease in disease activity decreasing over time with confidence intervals. They get narrowed down here just because there's more patients in that age groups. And if we separate high efficacy versus lower efficacy therapies, the lower efficacy, the oral medications had more disease activity, but you see how it comes down when we compare it to the higher efficacy therapies. And again, this would be the average across the two groups. But we can see that at some point, there's really no difference between these drugs that we can at least see statistically. And for us in the real world population that became around the age of 54 or 55, that there wasn't much of a difference between these drugs. This was a similar analysis that was done from clinical trial data where that crossover point was 40 years of age. And I think this is an important point about sort of clinical trial design, where in MS, a lot of the patients over 55 are not eligible for these studies. And our average age in a patient clinic is about 50 years, at least it is in our clinic. So we're cutting out almost half of our patients that we see away from clinical trials. And so that's one of the advantages, again, of real world, that we can see that maybe those higher efficacy therapies do have a better effect into the older ages of our patients in real world. So if this is the disease pattern, can we talk about disease treatment approaches? And the standard approach for treatment of anything in medicine is an escalation approach. It hurts a little bit. So you start with a little bit of medicine, and if it continues to hurt, you kind of keep getting stronger and stronger medicine. Here we can see that doesn't match up the disease course very well. You start off with this, you break through because the disease still is active, and then now at the end, you end up with higher efficacy therapies when the disease activity really is much lower. You can do high efficacy therapy. That's great, at least at the beginning. The problem is at the end, you may not need that high efficacy approach much more. And the discussion becomes, when can you stop it, or, other options. There's a trial I'll talk a little bit more that's now published called the DISCO MS study that's that was led by John Corboy, one of our section head here at the University of Colorado. Some of the drugs use a little bit more of an induction or maintenance therapy where you can do a course of therapy, and that's great. It might hold you for a little while, but then you might need to do some maintenance therapy because you're still maybe breaking through, and how to predict when to do that maintenance therapy becomes a little bit tricky. And one of the things then we'll talk about is this concept of de-escalation, where you'd start high efficacy, but then maybe step down through these drugs. And one of the things we still need to learn a lot about is when and how to go about doing those de-escalation approaches. So we talked about this a little bit from an efficacy perspective, but let's talk about on the safety side of things a little bit as well. This was a study that we did with 1,000 patients on rituximab, primarily with MS, but also included some neuromyelitis optica, and we included patients from NYU with Dr. Keister there as a collaborator. And we looked at the factors associated with infections. And so we looked at serious infections, and these were patients that needed to be hospitalized, required IV antibiotics or prolonged antibiotics, and looked at a number of different factors associated with this. We could do this just looking at different factors individually. We could look at it as taking everything into account with the multivariate model, or we can do sort of a stepwise selection to identify, some associations, right? So if a patient has higher disability, for example, usually that takes time, and so the age factor kind of starts to go away, and it gets rolled into the disability scores in the models that we were looking at. When you look at the factors associated with infections, you identify some of the factors that have been identified. Being male for this is not helpful. Twofold increased risk of having serious infections. How long you were on drug, doses, had you used chemotherapy prior to using rituximab. A lot of these things, had, again, factors of twofold higher risk. But I'd point out at this one, right? So this was the disability scores, and compared to people that needed no assist for walking, patients with a cane had a slightly increased risk in about 69%. But you start getting into patients with wheelchairs, and they had over an 8.5-fold increased risk of serious infections. Now, unfortunately, sometimes with B-cell depleting therapies, because of their indication for progression, the patients that were being put on these drugs were patients that were wheelchair bound, bed bound, and then people were surprised to see that all these patients were developing urosepsis, pneumonias, and things like this. And some of that is just the association from MS with the risks that are associated with it. And so this might provide a little bit of a balance of saying, hey, maybe if you start getting into the point where patients are starting to require a wheelchair, we should really start to rethink, their maintenance on B-cell depleting therapy. And maybe at that point might be a good step down for using some of our lower tier efficacy-wise medications. We can look at similar data from COVID. So this was the North American registry from COVID. We can see that as older patients, the risk of dying went really up. And we have columns here for hospitalization, ICU, or death associated with a lot of the same types of factors that we looked at before. We can look at as patients get older, the risk went up. Men, in this case, had a threefold higher risk. So again, we were seeing a lot of the same things seen with COVID. The risk of not being ambulatory was now 25-fold higher. And again, the things that we tended to be associated for the general public, cardiovascular disease, being obese, hypertension, these things were only in the range of 2 to 3-fold higher. So see how much higher risk you start to take on when you put these more disabled patients on these drugs. And so I think that helps us balance a little bit of making these arguments. When we looked at drug, for death, we didn't see any differences. When we looked at their effects on hospitalization, we could see some differences associated with B-cell depleting therapies primarily, and also with steroids. This effect on rituximab probably had to do more so, compared to some of the other therapies, probably was a bigger effect because patients on rituximab had been on rituximab much longer than those patients on ocrelizumab. Again, ocrelizumab was only approved in 2017, so rituximab has been used since way before that. Let's talk a little bit about just stopping. And I think as you're starting to approach this with the patient, how do you go about this rationally with the patient? And this was sort of a list of like maybe a little bit of a checklist that I kind of think about in having those discussions. I think the important thing is a lot of times is to plant the seed. So you might need to do this discussion gradually with a patient. You've been oftentimes taking care of these patients for several decades, and then you start talking about stopping treatment, and the patient really kind of has a sense of like, oh, you're going to drop me, you're not going to take care of me anymore. And so that gets really tricky to kind of be able to handle. Things to look at would be age, years of stability, and then the disability level, as we've talked about in the prior slides. The DISCO MS data is here. So this included 128 patients and 131 that continued drug. And if we look at relapses, it turned out that it was not inferior. We can say that confidently. There was one relapse in the continued group. There were 3 relapses in the discontinued group. So we would say there was no difference between these, but it was a non-inferiority study. And when you start adding MRI lesions, you end up with statements about non-inferiority was not demonstrated. So you couldn't say whether it was better to stop or continue. From an MRI perspective, only one of these patients that discontinued actually that had a relapse, and one out of really the 4 had MRI lesions to support that relapse. It was this patient with 5 lesions. And you also had a patient with 3 patients with 4 lesions. So if you look at the one patient that had maybe a true relapse versus a pseudo relapse, and those patients that had more MRI lesions, maybe discontinuing became a little bit difficult. If we look at that patient that did have MRI supported relapse, that patient turned out to be a patient who was 55 years, which was the youngest patient that could de-escalate. So again, things that we need to learn a little bit are, maybe 55 is the wrong cutoff. Maybe we need to wait, until somebody's at least 60. And so as we get more data on these studies, I think they'll help us inform about how to actually go about either stopping treatment or de-escalating. This is something we're trying to get more information on. So we have a retrospective study and we're up to 43 patients. This is a little bit of a sneak preview into some data that we presented at the end of the month at ACTRIMS. And one of the interesting things is, you can see these baseline characteristics. Surprisingly, I thought we would go for a little bit older patients, but, retrospectively, there are other many reasons why people might de-escalate, especially during times of COVID. And so for these patients, our average age was 48. We did look at disease activity while on CD20s, and then when they switched over to fumarates, and we can see that they're not that different, fairly similar. So I think we can sometimes predict a little bit better who's going to de-escalate. And we still need to break this down a lot more and understand sort of who was breaking through and what were the conditions for that. Were they people that maybe had been stable for less time? Were they the younger patients and those kinds of things? So we're, again, just kind of very preliminarily trying to do these studies. And now we have a couple of studies that are actually looking at this prospectively. We have about 6 patients in a prospective study that's going to switch from B-cell depletions to fumarates. And then we're leading some efforts in multi-site center looking at de-escalation to ozanimod, so an S1P inhibitor, to kind of be able to see if we can learn more about this as well. So those are a little bit of some of our efforts into comparative effectiveness and what we could learn from that from real world data. We can add in data for ocrelizumab. So just to go through a little bit of this before we start talking about more specifically just B-cell depletion therapy. Our experience with ocrelizumab was very similar to rituximab. Our numbers were maybe a little bit better with ocrelizumab. I think some of this probably reflects the fact that we had better access to ocrelizumab than rituximab, since it is approved and has a patient assistance program. And so we're not waiting to put the most aggressive patients on rituximab and could put more people on it. When we look at these differences, though, we didn't really see much of a difference between the drugs. When we look at it with propensity matching, rituximab versus Ocrevus, again, very similar between them. Borderline difference with natalizumab again, and much better drugs in the order of 3 times better than some of the orals. When we look at discontinuations, again, the loss to follow-up, insurance are primarily the main issues why we were losing patients to our studies. So again, some of the differences with real-world data. So especially with some of the B-cell depleting therapies, now that we're starting to get up to 4 different drugs approved with these medicines, how different are they? How do you pick between them? Has been sort of a big interest of ours, I think. There are differences between the drug. They vary in how humanized the antibodies are. With rituximab and ublituximab being chimeric, ocrelizumab being partially humanized, and ofatumumab being fully humanized. How they kill the cells are a little bit different, with more CDC by ublituximab and Ocrevus versus ofatumumab and rituximab. They're a little bit more on the ADCC spectrum of things. The targets on the cells are a little bit different. How you administer it is probably the biggest difference between these drugs in my mind, with ofatumumab being sub-Q and the other ones being infusions. You can look at the length of time of the infusions, which is a little bit of a moving target in these kinds of things. And so there are differences, but I think the differences are much smaller than what we sometimes are led to believe, maybe. And so I think that's helpful to kind of keep in mind. I think the good news is that stop inflammation. We'll show some data for that stuff. And the risks associated with the B-cell depletions are infections and infusion reactions, which again, we have seen with all of these different therapies. So from an efficacy perspective, we can compare the phase 3 trials for Ocrevus here with ofatumumab in the subcutaneous trials, and in the ultimate studies with ublituximab. We can actually look at Hermes study, which was a phase 2 study. So this was the primary endpoint on MRIs, but we can look at their relapse rate, and we can see that it had a really nice reduction and actually was statistically almost significant over the overall study, actually at 24 weeks. So again, these drugs have similar efficacy. The comparators are different, so that makes it a little bit harder to kind of compare cross-clinical trials to do what we're not supposed to do, and this slide was not meant to do. But I think it gives us a sense that they're probably really much in the ballpark of doing this. How good are these drugs? So we can look at things like no evidence of disease activity. And if you look at the overall studies for ocrelizumab, for example, the rates for overall NIDA, for example, you say, yeah, this is a hard goal to achieve. You only may be achieving it with ocrelizumab in half your patients, with the interferons in maybe a quarter of the patients. Yeah, there's some differences between them. If you re-baseline, though, you can see that NIDA can be achieved in 96% of the patients with ocrelizumab. So this is an achievable goal. I think this is the experience that we have in clinical practice with these patients, where these drugs work really, really well. The main reason we need to re-baseline is this one, because lesions start to occur early, and we can see that, and it takes a little bit of time for the drugs to take effect in the first few months. So if we re-baseline at 6 months, it gets rid of that metric, which brings all these numbers down, particularly some for relapses as well. And that's how we see and how we do in clinical practice. We can see this longer term with ofatumumab, in which case, as you start to look at these different time periods, the drugs gradually just kind of keep getting better and better with rebaselining, and you're achieving it in over 90+% of the patients on these drugs. So again, these drugs can have a huge effect on outcomes for patients. Now, again, this is an emphasis that this is on relapsing and not necessarily that they have a great effect on progressive disease. And I think that this is an area that we still need a lot of help in from a therapy perspective. And we can see that there might be differences primarily driven, unfortunately, by patients who have inflammatory activity, not clinically because it's a PPMS population, but at least by contrast enhancing lesions, where again, the benefits were primarily seen in those that had contrast enhancing lesions. Those that did not have much of a difference between these drugs. I think for some of this, how much is the data going to be extended to the other B cell depleting therapies? Well, we have a little bit of data from rituximab that looks very similar to this actually in a much smaller study. But we have no progressive data on ofatumumab and neither on ublituximab now. So where are we going to go with this? So this is the efficacy data. Let's talk a little bit about how you use these drugs and some of the tips now on what we see. So the most common side effect by far is infusion reactions. I think this is the thing we probably end up spending the most time on besides infections as a whole. We can look at interferons versus ocrelizumab from the OPERA studies, and we can see that the first infusion has much higher rate of infusion reactions. In the trial, only a quarter of the patients had infusion reactions. I feel like in real life practice, this number is much, much higher. And so we, how to talk to patients about this, I think, becomes important. Most patients and even most providers in the MS field keep talking about these being sort of like allergy reactions or anaphylactic reactions. It's a reaction to the drug. And basically over the next few slides, I'll try and convince you that that's not the case. One of the clues to that is as soon as you do a second dose, if you're reacting to the drug, that number should actually be higher and shouldn't drop. We can see that if we give it time, because this infusion is only happening 2 weeks later. So at this point, there's no B cells. And as the B cells start to come back, you start to see these reactions start to come up. Gradually with time, you kind of keep beating up those B cells. There's less of them there. And so the number of reactions kind of keeps going down and down. We could look this as well in patients that switched from rituximab, which was the comparator group in this study that we did that went on to Ocrevus. The switch over at 15 days, and then it kind of came back up. Again, we didn't see a difference between rituximab or Ocrevus in infusion reactions. The big difference was the timing around this. So when we looked at factors associated with infusion reactions, it really was primarily whether you had B cells present or not. This is practical tip number one, if you want to think about it that way, because the natural tendency if a patient has an infusion reaction is to actually wait to do your infusions and push them off because you don't want to have that reaction. But one of the tricks you can do is just actually do the infusion earlier before those B cells come back, and that might help reduce the chances of having a reaction. So this would suggest that it's a little bit more of a cytokine storm, that the chemokines and cytokines released with B cell depletion are what's giving you the reaction with these infusions. We looked at a bunch of different chemicals being produced, cytokines and chemokines, with the release of rituximab and Ocrevus, and compared them at 2 hours and 4 hours. And they're really, these again are differences in how these drugs kill the cells. And we could not see any differences in these cytokines or chemokines. The only one that was a little bit different, just barely with all these differences, if you did any like Bonferroni corrections, this would go away, was for IL-16 at 2 hours, where the levels were a little bit higher with Ocrevus. So again, it didn't matter how you kill the cells. We were just seeing differences in these chemicals as the infusion went on. So this is a little bit different from serum sickness. I like to highlight this because I learned this the hard way, so I like to pass on this tip. These are reactions that happen 7 to 10 days after the infusion. You start to get sort of a little bit larger hives. It can be associated with fevers. You get markers like CRP and ESR going higher. And this was a description of 5 patients that had serum sickness with rituximab in this case. And these are much more the reactions that you would kind of say are reactions associated with antibodies, so type 4 type reactions. And so again, the difference between these are the reactions that happen down the line 7 to 10 days. To go back a little bit at the reconstitution and maybe some of the differences between the therapies is this is what reconstitution looked like for us. So we don't change the dose for Ocrevus or rituximab very often. Rituximab mostly we do at 500 milligrams now, but in the past we used to do 1 gram fairly routinely. And you would see that One of the things that does change is how big people are. So small people versus big people. And the bigger you are, the faster, the more likely you were to have B cells present by the time you had an infusion. You're getting the same dose, you're bigger. So per kilo, you're getting a bigger dose. If we looked at larger versus low dose, people with larger doses took longer, had fewer B cells, had less of a chance of having B cells present at the next infusion. And we could actually look and see sort of where those lines kind of crossed over. It basically took 3 weeks for a large dose versus a small dose to kind of cross over. So the difference between a large dose and a low dose really didn't buy you much. It bought you 3 weeks on your B cells coming back. And that was part of the reason we started going from a gram to 500 milligrams of rituximab. One of the differences is with ofatumumab, you can see that the modeling of B cell depletion is very consistent. You just don't, you deplete them up front and then they're gone. You don't let them come back. And so this might have benefits as far as infusion reactions. And anecdotally, we do see fewer reactions with ofatumumab, and it's something we're looking at. Once you stop drug, the reconstitution does happen a little bit faster with ofatumumab. It's a little bit less of a smaller dose. So it's 20 milligrams every month versus 500 for rituximab or 600 milligrams for ocrelizumab. And so the reconstitution happens probably twice as fast. So 23 weeks for ofatumumab after stopping, and I think it came out to be like 100 and I'm spacing out 72 weeks when it started kind of come back. So if you run into issues like infections or things like this, the reconstitution is a little bit faster with ofatumumab to stop that, but again, it's not fast. And so that's where it becomes a challenge. And actually, I take it back, it's 46 weeks with ocrelizumab. So let's look at NFL a little bit, and just neurofilament, again, is that marker for loss of nerves. And we could see one of the trends that's been described a lot is that with age, as patients get older, NFL levels go up higher. And we could see this, and this was in the study again that looked at patients that went from rituximab to Ocrevus. And as they started Ocrevus, this was their neurofilament light level. So we could see that if we use a cutoff for what's normal, we could see that primarily the patients that had slightly higher levels, and most of these patients had very normal levels, were patients that were older. So as you might expect, that they would just be on that spectrum of just naturally being a little bit on the higher percent. And so to have, in this case, exactly 5 out of 100 patients, which were in the study, that, that gets you in sort of in the reference range of what normal might be and not be. The biggest factor, I think, is also BMI. So you can see all 5 of the patients were on the lower BMI spectrum compared to bigger patients. And so the issue here is you have less blood volume, and then you concentrate the NFL. So as we look at NFL, it becomes important to kind of be able to adjust for these factors. And the test that's available commercially at this point, whether we look at through Mayo Clinic or some of the Octave panels and things like this, are not very good at adjusting for these factors. And you end up with curious observations. For example, if you are fully B cell depleted, your NFL levels are likely to be higher. Well, we normally want patients to be depleted because that means the drug is a little bit higher dose and more effective. But again, to be depleted, usually that's smaller people who concentrate neurofilament light levels. So again, statistically, we don't see that, but as a trend, to see that the non-depleters actually had lower levels of neurofilament light suggests again that we need to really kind of focus on how to balance these drugs. One of the places that we've used B cell depletion a lot has been in pregnancy. So again, this is the phase 2 study on an MRI perspective. We can see that after treatment, there was no treatment for up to a year, which is great because it allows you to have a period of time where you could try for pregnancy. 9 months fits in nicely. You can have a delivery and another infusion before, after that. And one of the places that we've started to kind of look at, and we'll have some data at ACTRIMS as well with Dr. Shaw here, is then look at B cells in babies, where we could see that those babies did not that those babies had normal levels of B cells. And that was for allowing for lactation. So again, moms are able to make it through pregnancy well, have good outcomes. We're collecting that data as well, and be able to breastfeed afterwards without the babies absorbing those B cells through breast milk, and they just chew them up. I think the important point here is to space it out by at least 2 weeks, so you get away from the colostrum where the baby could absorb some of those antibodies in breast milk. Let's look at safety factors. I think things to note is that, you do get some lymphopenia with these drugs. This is going back to that safety paper looking at infections on rituximab. And low levels of lymphocytes happen in some of these patients. Here I separated MS versus NMO because it gives us an indication about higher doses. I think primarily NMO patients, again, getting probably closer to the gram, 2 grams of rituximab every 6 months versus the 500 milligrams in MS. And we can see that there were almost 3 times as higher to have the lymphopenia levels. If we look at immunoglobulin levels, we can see that much more likely to have higher levels of hypogammaglobulinemia with these higher doses. And so I think this becomes something that we need to be aware of and look at periodically, because it can happen, and it's not uncommon to see immunoglobulin levels below 300, for example, which have definitely been associated with infections. From the clinical trials and a lot of the marketing studies that you will see, and this is just maybe my soapbox a little bit, is they will associate that there's no risk of infection with low levels of IgG, but their cutoff for what a low level of IgG is just lower limit of normal from the lab test, and it doesn't necessarily reflect concerns where antibodies are. And these are kind of more traditional cutoffs where you might start to see infections associated with them. And again, we were seeing adverse events associated with low IgGs in this study. So what are the rates of decreasing immunoglobulins? We saw very similar numbers in IgG. The numbers aren't big, so this was kind of our first cut. And I'm going to skip this to say the numbers are much bigger for IgNs, but these are less likely to be associated with infections. Ofatumumab will make a claim that it's not associated with decreasing immunoglobulin levels. However, they had cutoffs where patients could not get treated if their immunoglobulin levels dropped. And so particularly over 14% of patients in just a 1.6-year study had to have a treatment pause or discontinuation because of this. So if you stop drug, you're not going to continue to have decreases in antibody levels. And so I just, a little bit of a backstory to, I think, some of their data. This is a little bit what the decreases look like, and we can see decreases of about 2 to 3% per year of immunoglobulins with either ocrelizumab or rituximab in our real-world studies, where we let them drop a little bit more. So these are log linear curves just because it is fitting a log linear decrease. Most patients do just fine, but it's this patient that I would worry about. And if you don't look for it, you're going to miss those patients. Ofatumumab looks very similar to that. Here we're looking at effects of BMI. I wouldn't believe these numbers yet. This is very preliminary data, but just to kind of show that we do see some decreases with ofatumumab in the real world in our studies. The other thing to think about are neutropenic fevers. These are uncommon, but we've seen now at least a handful of cases, and it's something to be aware of. They're less scary than they sound, but these are patients that show up with neutrophils of 0 and with fevers. We've had one case of Ocrevus 4 on rituximab. We actually probably have double this number. We're working on collecting some new data for a series now. But this is kind of what it looks like. They're doing fine, they drop. They're doing fine, they drop. Part of what we did, and I think traditionally sometimes we think about, is to do GM-CSF to kind of recover the neutrophil counts. Usually these are associated with an infection, and we can see that they bounce back. This patient actually had 2 neutropenic fevers, and so they seem to be a little bit more prone once you've had it to continue having it. The rapid return of these suggests that this isn't a bone marrow suppression. So you may not need to do GM-CSF, which can boost the immune system. And in a disease where you're not trying to boost the immune system, theoretically, that might not be the best option. And so by treating just the infection, it seems like those neutrophils come back. So our thought is that the neutrophils are there, they're just at the tissue trying to fight the infection, and there's some transport issue that gets affected on these drugs. We could talk a little bit about vaccinations in the last minute or two here, and I think it becomes important to recognize that the responses to vaccinations are decreased. The Veloci study with ocrelizumab looked at about 100 patients, and we can see that the response to different antigens is decreased. This is mostly on the humoral side, so antibodies to tetanus or keyhole limpet hemocyanin are decreased. These are basically as a model for novel antigens, and then for things that you've been exposed to in the past, it's also decreased. The placebo arm was 34 patients, and that's the control arm for all these other components that were looked at. But again, no matter which vaccine you're looking at, the response was decreased. We looked at this early with COVID vaccinations and some of our healthcare providers that were vaccinated very early. And again, with a number of different B-cell depleting therapies, including ofatumumab, the chances after the first vaccine were much lower to develop antibodies, although some of the patients after the first vaccine who were controls, some of the healthcare providers that worked at the clinic, most of them actually had a good response even after just one dose. So the 2 doses might be a little bit overkill, but again, the lowest person still made better antibodies that was not on B-cell depleting than those that were. This has now been shown by a lot of other groups, and I think very similarly shown here from the Penn group with Amit Bar-Or. On the humoral side, I think one of the things that this paper, which was really well done, shows is that if you delay those infusions or at least let for those B cells to come back, that you can then start making antibody responses. The important point is that you then, because of these studies here, that that the vaccines don't work in patients, that we shouldn't bother maybe vaccinating patients and things like this. And the important point is that from a T cell response is that these patients did form T cell responses. And so it's important to vaccinate patients. You are getting some protection across the board, and it didn't matter how soon you did it or where you did it. So if you're having to vaccinate somebody, vaccinate them. You could always boost them and worry about that a little bit later. So with this, I'll finish and just kind of say that choosing the right medication requires balancing this efficacy versus risk-benefit tolerability, that the real-world data can help us understand this better, and that high-efficacy therapies only have higher efficacy really early in the disease course, and that the risk of the higher efficacy therapies is lowest early, but really can start to increase later on in the disease course. And so with that, that's not the right code. I apologize for that. But I'm happy to take questions.
Well, maybe I will start the questions off. And, when you're thinking about patients as they age and whether you can stop your drug, there's several factors that might be the more important one. And is it just their age, or is it the time that they've been on the drug, or their level of disability, or the progression? What do you think? Why is it that we're sometimes able to get away with stopping their drug?
Yeah, no, it's a great question, and it's 100% the challenge of answering that question, right? I think when we start to kind of just preliminary look at the people who had done that in the retrospective side of things, the reasons vary a lot. Some people were because of infections, some people were just insurance issues and things like that. When we looked at this, I showed the effect of age. I think age is a big one. I think disability is a big one. I start to kind of see a wheelchair and I start to say, hey, maybe we need to back off. We looked at disease duration. And it provided the weirdest curves I have ever seen in any analysis ever. And I'm still trying to understand them. We showed them a little bit at Ectrum's a couple years ago. I think the problem that we run into with high efficacy therapies, and this is kind of something that we're starting to look at a lot, is that most of the relapses, if we want to do air quotes around that, are really pseudo relapses. A patient comes in on these high efficacy therapies, they have some symptoms, and we're like, it's not a relapse. And you do everything you can to try and identify, what kind of infection is leading to that, or what's the cause for that. And so what we actually saw for disease duration is that as patients age, they actually had more disease activity, which doesn't make sense with what we see in practice or things like that. And so I think that that's the effect of the pseudo relapses. But you're absolutely right. It's hard to talk about age when we know that we see patients who have been diagnosed at the age of 65 to stop treatment at age 60, right? They broke through on nothing. So we know that that's not a great strategy by itself. And it tells us that we need to kind of put all those other components into it. So I like to be stable for at least 5 years. And if I can get away with 10 years, that's a much better marker, practically from, in my mind.
A separate question from that is the DISCO MS study was underpowered, and there are two other studies going on in Europe with the French group or the Edmonds group, and then one in Amsterdam. And do you think it will be possible? They're even more underpowered with fewer patients, but do you think someday maybe a meta-analysis will be done so that we can get enough power to cross the statistical threshold?
Yeah, I'm really hopeful. So the Stop MS, which was the Amsterdam study, actually got terminated early because they started to see a signal difference. And I think one of the learning points there was that the average age in that study was, I think, high 40s, like 48 or something like that. And so it's telling us that stopping treatment, we might be able to get away with it, but we can't get away with it in the 40s. 50s might be a little bit harder. And again, this is probably a little bit more like Vegas, where it's probabilities, right? More so than like, oh, I'm 55 in 2 days, now I can stop drug. And so I think that that's what we're going to learn. I think the factors of trying to put all those things together is going to be what's going to be helpful from that meta-analysis.
See Dr. Fong popped in there.
Hi, Dr. Alavarez. Thank you for the talk. Very interesting, and for sharing your real world experience. I'm one of the MS specialists at the Swedish MS Center. Question about de-escalation in middle age. You had mentioned de-escalating to fumarates. I'm curious your thoughts on cladribine, which I like to consider like an exit strategy, given that in a majority of patients, based on the clinical trial experience, 55% were stable without need for further disease-modifying therapy, 10 years average follow-up later. So when I'm thinking about trying to transition off, I favor that approach, given it's relatively high efficacy. It's been studied up to age 65 with similar benefit and safety for the patients that are 50 versus younger than 50. Sorry, older than 50 versus younger than 50. What do you think about cladribine as an exit strategy?
Yeah, I think it's a possibility as well. I mean, I think from induction therapy up front, and maybe it clouds my judgment a little bit, in this approach as well, is the breakthrough on those drugs was about a third of patients at years like 3, 4. But I think this is the place where you would use those drugs, right? It's at the tail end where you're trying to de-escalate. I think partly it's the idea of like as you de-escalate, how close are you to stopping treatment, right? If you think of that, how steep is that ladder that you're going to use to de-escalate? And so if you're using it in patients that are, the 55s and 60s, maybe I think cladribine would be something I would much more likely to push through. If you're kind of de-escalating somebody in their 40s, maybe I'd be a little bit, more favorable of something that you're going to continue on for a little bit longer. And whether that's like an S1P versus, a fumarate. And the other one I think that we sometimes don't talk about much either is teriflunomide or Aubagio, just because, it's probably a little bit of a step down, right? And so how many rungs are you going to put on the stair? Do you go to the fumarates, and then you go to an Aubagio, and then you go to off, right? And those kinds of things. But I think, probably the why Aubagio looks so good in real world studies a lot of times is because there's a self-selection to using it in these kinds of patients. That probably extends a little bit to the cladribine use as well, in these older patients and things like that.
I'm glad you brought up teriflunomide because from the recent evobrutinib study and then like looking at disability progression compared to ublituximab, it performed better than expected. And I'm wondering, given that particularly in older age, we worry more about, worsening symptoms from progression rather than relapses. Is teriflunomide a better option if we're trying to slow down progression? A safer option too.
Yeah, no, for sure. I think it's definitely in the discussion, from a de-escalation perspective. I think that the efficacy on the evobrutinib studies are just really challenging to understand, because if you look at the relapse rate in the teriflunomide arm, it was almost as low as the ublituximab arm was in the ultimate studies. There just wasn't a lot of events captured. And so my hesitation a little bit from that trial is that's a study that is going to be really complicated to understand, thinking that the vast majority of patients were in Ukraine and Russia. How well was ascertainment of relapses? These patients were being evaluated in all these other centers. Were you missing events? Is that why there wasn't a difference? Was it just that teriflunomide somehow got superpowers, as it stays on the market longer or went generic? It's going to be interesting to see as these other BTK studies kind of come up, kind of how good teriflunomide is or how bad the BTKs are.
Right. And you kind of illustrated the fact that a geopolitical issue beyond the control of clinical trials probably had a major impact on the results.
Yeah, it's kind of scary, but there's a lot of patients that really had to seek care elsewhere for large parts of that study.
Mm-hmm. And then I'm glad you brought up disco MS. And one curiosity I have, this is an older population group who may have non-specific white matter lesions. I'm just wondering, like, how did they count any lesion? Was there a size, like, threshold? Like, was it definitely an MS lesion, or could it have been from anything else?
So a couple of comments on that. One, it's a great question in the sense that the MRIs were standard of care MRIs, so there was no coverage for them. So they happened sort of as they happened, which makes it tough. They did have to be, I think, 3 millimeters to be counted, but it doesn't necessarily mean that they looked at things that maybe could have helped us with that question, right? So in our de-escalation studies, one of the things we're doing is looking at central vein sign so that we might be able to kind of comment on like, hey, for some of the subcortical lesions, are they maybe a little bit more likely to have been MS related than not. Mm-hmm. And that clearly was not done, for the DISCO study. I think that that's where a little bit sometimes when you look at like the Rio criteria and things like this, where it's like, we're okay allowing 1 or 2 lesions. And that was the focus of like, hey, I would focus on those patients that had 2 or more lesions, as likely being the patients that maybe had real MS lesions. And those were all in the discontinue arm.
Those are all my questions. Thank you.
No, awesome. Great questions. Thanks.
Well, it looks like we made it to the 8:30 mark and a little beyond. So we'll cut off the questions. And I just want to thank you for giving a great presentation and for presenting to us today. So thanks.
Thank you very much.